Greg, nice to meet you. It's so nice to have you here. Do you think you could first tell me a little bit about yourself?
Sure. So I'm the Vice Chair of Patient Safety and Quality Improvement for the Department of Anesthesiology at UNC Hospitals in Chapel Hill.
Okay. Oh, big job. I have the right guy here to ask these questions.
Yes,
huh?
it is a big job.
Okay, great. So I don't know if you know, but I'm a general internist. And so some questions have been coming up about these medications, these GLP-1 or glucagon-like peptide 1 agonist drugs that are ubiquitous. We're using them for weight loss and for diabetes. And I probably saw 6 patients yesterday that I had on them in my clinic. So a lot of use of these medications. And recently, I had been hearing from some of my patients that they were concerned about some of their procedures that they had coming up while taking these medications. So I was wondering if maybe you could help me understand what some of the controversies have been about these medications and procedures.
Right. So the American Society of Anesthesiologists recently released a guidance. It was not a guideline, but a guidance on how to manage these medications. And this was based on the perceived risk that patients might be at a higher risk of aspiration during the intubation phase or the controlling of the airway phase of anesthesia. And as an anesthesiologist, we're sort of taught that's one of the things we fear the most in our line of work. And so it, as you would expect, really got the attention of my colleagues and myself. But it also got the attention of the mass media. It's made it into the general media. And so I think even patients have been alerted to this concern. And so that's where it really originates. Now, there's a lot of things that go into the risk of aspiration, and we're used to evaluating that on a daily basis on every single patient. Simply the act of having long-standing diabetes would put a patient at a higher risk of aspiration because they may have developed gastroparesis because of the disease itself. Pregnancy puts a patient at a higher risk. Any number of GI pathologies can put a patient at a higher risk. And so this is just one more thing that we've got to consider as we care for our patients and plan our anesthetic management.
Okay. But what I think I'm hearing is that you look at the individual patient and their risk factors, and one thing like these medicines would not be the final determinant.
Right. I think that's the most important thing that people have to remember with this statement that was put out by the ASA. It is to be added to the big picture of what is the global risk factors for this patient. Plus, what are the risk factors if we do something different? If we change our anesthetic plan, that comes with its own risk. If we cancel a case, that comes with its own risk. It could be a big disservice to the patient. They've already taken time off of work. They've got a loved one that took time off of work to care for them postoperatively. And so it's not a simple one variable risk evaluation. It's a multivariable risk evaluation we have to do.
Okay. So as the internist, and I'm referring my patients for cystoscopies, endoscopies, colonoscopies, I, at this point, would not tell them to expect anything differently than they've had in the past with those procedures, even if they're on these medicines. They will just have a conversation with the anesthesiologist at the time. And should I prepare them any differently?
So the ASA statement suggested that patients hold the medications if possible before surgery. And that was irrespective of why they're on the medications. If they're taking it on a daily basis, they suggested just hold it the day of surgery. If they're taking it weekly, they suggested holding it for a full week. Where I personally have a problem with that is that doesn't make a lot of sense from a pharmacological standpoint. Holding a medication for 1 week when it has a half-life of 1 week is not likely to alter in any way their risk from gastroparesis and aspiration. And what we have done is alter their diabetic management at that point, or potentially their weight loss if they're on it for that purpose. But we've altered their other course with no known benefit on our side.
Okay. So it sounds like locally we're not that interested in that treatment or prevention plan. Is that right?
Yeah, locally about the most we'll do is at our preoperative clinic, we will broach the subject with the patient and let them know that this is out there and that this is, been released by the ASA, and to consider discussing with their their primary physician, should I hold this a week beforehand? Should I hold it on the day of surgery? And let them help us balance that risk.
Okay. Would it make more sense to make a patient NPO longer rather than to hold the medication that is probably not going to be out of them anyway?
Yeah, so there's definitely been a lot of talk about that, and a lot of people have considered that as a possibility, but it again goes to, we got to remember the implications that might have on a patient.
Right.
Being NPO for, 8 hours is uncomfortable. Being an NPO or on a clear liquid diet for longer than that just gets worse and worse. And the reality is we do not have evidence at this point to support that. The exciting thing is there are people at UNC, and I've talked to colleagues throughout the country that are trying to do studies as we speak so that we could better understand this in the future. But right now we simply don't have the evidence to make that request.
So we have some case reports, but we don't really have any randomized controlled data telling us to hold medicines, to make people NPO longer, just to consider these as one more risk in the aspiration possibility.
That's exactly right. There's no randomized controlled trials. The guidance was purely based off of several case reports, which we all know we have to be very careful about making generalized statements, guidelines, policies related to just a handful of case reports.
Right. Case reports are anecdotes.
Exactly.
Right. Okay, wonderful. And is there anything else that you'd like to share today?
No, I just think, like I said, this is something that we as anesthesiologists need to be thoughtful about. We need to add it to our risk profile, add it to the variables we consider, have open discussions with our surgeons and our proceduralists about it. And then we need our surgeons and proceduralists to be open to the fact that this is a new and developing area, and that there will be variability in the responses based on what any given patient presents to us.
Okay.
Patient A may present and have no symptoms, and they've been stable on the drug for months, and we might go with plan A. Patient B shows up, they just increased their dose when they saw you last week, they've developed nausea, vomiting. As a result, maybe we alter our plan or alter our statement for that given patient.
And for right now, as a primary care doctor, I would not make any adjustments for my patients. And I would tell them when they go for their screening colonoscopy, I don't anticipate any significant change in what happened from this colonoscopy to your last colonoscopy.
Yeah, I think that's fair, especially if they're asymptomatic.
Okay, great. Greg, thank you so much for being here today.
Thank you, Amy.